similar to except for Maharajah. So conclusion, mean T3, mean people, free T3, free people, they are lower in needed sepsis. And among the babies with actually sepsis, those babies who did not survive, those who died have worse actually thyroid status as compared to survived babies. And implication as whether thyroid hormone supplementation and admission in units increase the overall final outcome. So this is a theoretical proposal, and these are the possible putative mechanisms why thyroid dysfunction can occur in sepsis, mainly suppression of hypothalamic retinal action. So there is very limited literature needed, so we have sample. Thank you. We were appropriate in the time as 18. So the cytokines as well as the automated mediators are like inhibitory influence. They have inhibitory influence over the hypothalamic pituitary thyroid action. Good. Go to the previous one. So the cytokines, they act mainly on the hypothalamic pituitary thyroid axis and they inhibit the TSH secretion. So instead of actually thyroid hormone like T3, T4 being less, the TSH may not rise.
Many more doubts can be clarified at the time of tea time. Thank you.
Now I invite Dr. Ramakrishna, postgraduate in general surgery, to present a rare case of dermatofibrosarcoma purpuraris.
Good morning, everyone. Today my presentation is about a rare case report of dermatofibrosarcoma purpuraris with satellite nodule. It was the first case reported in Mims. Coming to chief complaint, a 40 years female came to our surgery OPD with chief complaint of painless light lower quadrant groin swelling since 1 year, and there are no lock infections nearby. And past history, family history, surgical history, and all our systems are irrelevant. And on local examination, a single arc non-tender, well-defined 5 to 8 centimeters, swelling in the right groin region, 2 inches above the inguinal ligament, mobile with multiple satellite lesions, and skin is not visible over the lesion, and there is no regional lymph node. And we investigated the patient with ultrasound abdomen to know the extent and infiltration of the tumor, and it shows the tumor is confined to the parietal region, and chest X-ray was done to rule out any pulmonary nuts, and other investigations were within normal limits. And we planned the patient for surgery with wide local excision with 3 centimeters margin. And these are the intraoperative photographs. And this was the primary lesion excised with 3 centimeters margin all around, including the satellite nodule. In spite of this wider resection with 3 centimeters margin, without any need of graft or flap, by mobilizing the facial potential flap, the defect was closed primarily. And post-op histopathological report shows spindle cells from upper dermis, which is storiform pattern, arranged in storiform pattern of cartwheel pattern, which is a gastric piece of this tumor. And all margins are R0 is nothing but a resection in the tumor. And it is of intermediate grade. And follow-up, this patient was sent to Mahatma Gandhi Cancer Hospital for adjuvant radiotherapy, and adjuvant radiotherapy was not given because the tumor is R0. And she attended 2 OP visits, no specific complaints. And coming to discussion, this tumor is low to intermediate grade soft tissue sarcoma. Previously it was attributed, it was originating from fibroblastic, but now later study shows that it was originating from the mesenchyme. And in 1924, Gary and Fernand coined the term progressive and recurring dermatofibroma. And it has locally destructive growth. It can even invade facial muscles or bones. And pseudopods or chemical-like extensions are thought to be responsible for its local recurrence. In dermatology, 0.1% of all malignant tumors and 2 to 6% of soft tissue soft tissue sarcoma, and 1 to 5 cases per 10 lakh per year, and in India it was around 5 to 8, and blacks are commonly affected than whites. And congenital dermatofibrous sarcoma protuberance is recognized but uncommon. Genetics was thought to be originated from the cutaneous mesenchymal stem cells which code for surface protein nestin, and more than 90% of this tumor exhibit this cytogenic abnormality and chromosome 17 and 22. And this abnormality was thought to be the fusion of platelet-derived growth factor B gene and 22 with collagen 1A1 gene. And this factor was not. Staging according to short term guidelines, local tumor is grade 1, nodal dissemination grade 2, and metastatic disease grade 2. And apart from this routine tumor, there are microscopically some rare types. Bednar tumor is nothing but a pigmented null deposit in the stroma and myxoid with the interstitial leucine in the stroma. And this fibrosarcomatous dermatofibrosarcoma protuberance is having poor prognosis and is having similar features like fibrosarcoma. And signs and symptoms, usually it starts like slow, painless cutaneous thickening. Later, over time, they can turn into large nodular mass with large fungating lesion with ulceration. And at the time of presentation, they will be less than 5 centimeters. And the delayed diagnosis of this lesion is due to like differential diagnosis like lipoma, cyst, hypertrophic scars, and common location is in front, followed by lower extremity, upper extremity, and head and neck. Diagnosis based upon the location of the tumor and size, we can go for core needle biopsy or open incisional biopsy. And FLAC is only established in case of recurrent disease. And chest X-ray, CD for rule out any pulmonary mets. And MRI is helpful for local extent by in the larger tumors. And pathologically, monomorphous spindle cells arranged in story form or whorl pattern. And Grange zone is nothing but a demarcation between the normal and abnormal ellipse. And there is extensive positivity seen with CD34 staining. And chromosome abnormality can be studied with the help of fluorescent in situ hybridization technique or RT-PCR. And treatment less than 1 centimeter lesions can be treated by dermatology people in the outpatient setting. But more than 5 to 6 centimeters tumors, they are treated with multidisciplinary approach. And mainstay of treatment is surgery. And recommended guidelines is 2 to 4 centimeters margin. And Mohs surgery is nothing but a microscopic oriented histographic surgery. With the advent of this surgery, the recurrence is dropped to 98%. And imatinib is another drug which inhibits 2 additional kinases c-KIT and PDGFR according for its efficacy. And prior to the treatment, molecular analysis should be done. And chemotherapy appears to be little utility. And adjuvant radiotherapy can be given for the larger tumors which are having deeper infiltration. And the adjuvant radiotherapy can be given to avoid mutilation of functional impairment. In summary, general prognosis is excellent. Overall risk and status is 5%. And with the advent of Mohs surgery, the recurrence is dropped to 98%. Thank you.
The photograph you have shown, the replaces of scarring, and that sort of multinuclearity usually don't present like that. It will be usually a single tumor mass. So scarring is there, multiple nodules are present.
Yes, exactly. It was the primary. It was having satellite nodules around the primary lesion.
So they didn't give any history.
No, because